so much for joining us today, everyone, for our Lunch and Learn session on early discharges among people who use drugs, opportunities to improve and prevent against medical advice discharges with Dr. Sara Ling. My name is Laura Clark, and I'm the Director of Advancement at the Lawrence S. Bloomberg Faculty of Nursing. Firstly, I'd like to thank Laerdal Medical Canada for supporting this event today. Their investment in professional development for the nursing community is very much appreciated. I also wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Just a couple of housekeeping notes before we begin. We're going to ask that you please keep your microphone muted during the presentation, but we do welcome you to enter your questions in the chat box. We will have a Q&A period at the end of the presentation. This session is being recorded so that we can share it with those who are not able to join us today. We will send you an email after the presentation with a link to the recording, as well as a survey that we hope you'll complete to give us some feedback on today's event. And now it's my pleasure to introduce today's speaker. Dr. Sara Ling completed a Master of Nursing with a collaborative specialization in addiction studies in 2014 and a PhD in 2022 at the Lawrence S. Bloomberg Faculty of Nursing. Dr. Ling currently works as an advanced practice clinical leader at the Center for Addiction and Mental Health, where she provides clinical leadership support to inpatient addiction services. She has worked at CAMH in direct care and leadership roles for the past 12 years. Her clinical research interests include withdrawal management, care of people who use drugs, and sex and gender-based analyses. Thank you so much for joining us today, Dr. Ling. I'll hand it over to you.
Amazing. Thank you so much for the introduction, Laura. And I am just going to share my screen. If I can get back to the Zoom call. Sorry, I've lost the visual of the Zoom. There we go. Sorry about that. Okay, can everybody see the slides okay?
Yep, looks great.
Okay, amazing. All right, so good afternoon, everyone. Thank you so much for being here with me today, and happy St. Patrick's Day. So the title of my talk is Early Discharges Among People Who Use Drugs, Opportunities to Improve and Prevent Against Medical Advice Discharges. So first, I'd like to lay out the objectives of my talk today. And I'll be taking you on a bit of a journey, beginning with some background and introduction to early/AMA discharges in general. And then we'll focus in on a discussion about early discharges from acute care settings among people who use drugs. Then I'll introduce you to my PhD research, which focused on early discharges from inpatient withdrawal management settings. And I'll share with you some key findings from my work. And then last but not least, of course, we will talk about potential next steps and future research based on the state of our knowledge to date. So first, it's important to define against medical advice or AMA discharges. And AMA discharges are defined as the formal recognition and documentation of a competent patient's choice to decline further inpatient medical care and leave the hospital prior to a recommended clinical endpoint. And this definition seems to accurately represent how AMA discharges are understood in most of the papers and research that I've read about this subject. So now I'll give you a brief history of AMA discharges, and they're both a designation and a process. And so this designation has been used in inpatient healthcare settings since at least the 1950s. And this term and designation is still commonly used in clinical practice today. And so typically an AMA discharge involves having patients sign an AMA form. And this is an acknowledgement that they're aware of the potential risks of leaving early and that they're assuming responsibility for those risks. And so here's an example of a typical AMA form that would be used in a hospital. And you can see that there's a place for the patient to sign and that they're signing off that they're assuming responsibility for their removal from the hospital. And so why do we designate discharges as AMA, and why do we ask patients to sign these forms? And essentially, they're designed to avoid culpability if a patient has a poor outcome after their discharge and were to pursue litigation against a hospital or care provider. And the intent is that they serve as proof, in addition to clinical documentation, that a discussion took place. And so when a patient expresses intent to leave a hospital early, it's recommended that their reasons be explored and contributing factors rectified whenever possible. And in addition, the patient's capacity should be assessed, and a discussion regarding the possible health consequences of leaving early should also occur. And then if after this discussion, the patient still wishes to leave, it's recommended that discharge and follow-up instructions be provided to the patient and that they sign an AMA form. And so this recommendation comes from the Canadian Medical Protective Association, as well as the College of Physicians and Surgeons of Ontario. However, there are some criticisms of this against medical advice language. And some have said, it's stigmatizing. This language is stigmatizing, it's antagonizing, it's paternalistic, it places blame on the patients, and it doesn't acknowledge the role of the healthcare system in contributing to some of these discharges. And so as we know, the words that we use really matter in terms of patients' experiences of care. And so there's been increasing recommendations in the literature to change the language of against medical advice to more neutral terminologies such as patient-initiated discharge, informed discharge, or early discharge, which is what I landed on for my own research, although I could use any of the others. So there are certainly more concerns and criticisms about the AMA discharge designation and the process of it, but I want to put a pin in that conversation for now, and we'll revisit it later, as I think it will be a richer discussion in the context of some of the research findings that I'll share with you in the coming slides. So at this point, I'd like to highlight some healthcare system implications of early discharges and give you a sense of why they're a concern. So this pie chart, it reflects data from a report from the Canadian Institutes of Health Information. And it shows that between 1% and 2% of all acute care and ED visits in Canada end with early discharges. And although this is a small percentage, it represents tens of thousands of early discharges per year. And what's particularly important to highlight about early discharges is that numerous studies have demonstrated significantly higher rates of 30-day readmission and ED visits among people who have early discharges compared to those who have planned discharges. So this bar graph, it shows the percentage of people who are readmitted within 30 days of their discharge by whether their discharge was planned or early. And you can see that those who have early discharges are more than 2 times more likely to be readmitted to hospital within a month compared to people who had planned discharges. So you can see, 24% among those with early discharges versus 9% with planned. And further, this high report, it also highlighted that people with early discharges are more than 3 times more likely to visit an emergency department within a week of their early discharge compared to those who have planned discharges. So there's some pretty significant system implications here and repeated encounters with the healthcare system. So here's a similar bar graph showing American data, and you'll see that there are similar rates of 30-day readmission shown that were shown on the previous slide, so quite similar numbers. But the reason I highlight this American data is because this study actually quantified the fiscal implications of readmissions among those with early discharges. And they found that they cost the healthcare system $800 million annually. And so now, of course, this number would be much smaller in Canada, given our smaller population, so maybe a tenth of that, but you get a sense of the significant cost to the healthcare system. So early discharges, they also have significant human costs. And so on this slide, you'll see that I've included findings from just 2 studies as an example, but there have been many studies showing increased adverse outcomes among those who have early discharges compared to people who have planned discharges. So for example, there's one study, they found that among patients being treated for acute poisoning by what they called substances of abuse, those who had early discharges had 5 times the risk of a repeated poisoning within the 1-year follow-up study inclusion period. And they were comparing that with people who had planned discharges. Another study by Garland, they were looking at people, all kinds of different patients, all different clinical populations, just receiving care in an acute care hospital. And they found that those who experienced early discharges had 2.5 times the risk of death during the 90 days following their early discharge compared to people with planned discharges. And so the natural next question might be, what are the characteristics of people who have early discharges? Who are the people who are leaving early? And I suppose by the title of my talk, I've already given away some of the answers here. But this Kai report that I cited earlier in the presentation, it answered just that question. They found that people who had early discharges were more likely to be younger males, people from lower income neighborhoods, and people with a history of substance use. And in fact, many studies have shown that early discharges from acute care settings disproportionately affect people who have substance use and or mental health concerns. So now we'll delve into a discussion of why people who use drugs leave early from acute care settings. And there have been a few qualitative studies examining this issue. And so I'll start with McNeil, which is a seminal qualitative study on this topic, and it's been cited many times. And so this study was based in British Columbia, and they examined early discharges from acute care hospitals among people who inject drugs. And they interviewed 30 people. And in this study, the participants reported that they had experienced inadequate pain and withdrawal management. And for some of the people, they continued drug use while they were in the hospital in an effort to mitigate some of the pain and withdrawal that they were experiencing. And so this further complicated their hospital stay and their interactions with the clinicians. Some also reported experiencing disruptions in their dose and the timing that they received their opioid agonist therapy. And so they were talking about, in this study, I think the patients have referred to their methadone dose, but this also contributed to cravings and withdrawal symptoms. Patients also talked about experiencing stigma and that they felt that staff perceived them to be drug seeking. And this was the reason why they were experiencing inadequate pain and withdrawal management. They also reported being subjected to increased surveillance and searches, particularly when clinicians suspected that the patients were continuing to use substances while they were admitted. But this compromised their ability to engage in harm reduction practices because, for example, some might lock themselves in a bathroom to use or reuse old needles that they had because they couldn't get new ones. And so ultimately, these participants, they described concerns about the implications to their health if they left the hospital early, but they just felt that remaining in hospital was untenable for them. Another study by Simon, they They interviewed 15 people with alcohol and opioid use disorders who had left early from an acute care hospital in the States. And similar to McNeil, these participants described having undertreated withdrawal and craving, undertreated acute and chronic pain. And they also talked about their challenges with some of the hospital restrictions. So they described that, they were unable to kind of come and go to get fresh air or to smoke cigarettes. And they found this, the restrictive hospital environment very challenging to remain in. They also talked about experiencing stigma, and they described this experience of mutual mistrust, where they felt that they didn't trust their care providers and that their care providers didn't trust them. And that created a great deal of difficulty, obviously, in establishing therapeutic relationships and rapport. And they felt that they were subject to discrimination because of the fact that they had a substance use disorder. Another study by Carasone, this study involved interviews with 24 adults admitted to acute care hospitals in Toronto and in Ottawa. And this study focused on acute care experiences of people who use drugs. And so it wasn't explicitly focused on early discharges, but what they found was that for many participants, early discharges were the outcome of their admission. And so, quite similar to the previous two studies that I have described, participants reported experiencing insufficient or inconsistent pain management. And they just had these general perceptions that they were receiving lower quality care, and that really they weren't receiving the same standard of care as people who weren't using drugs. Another study by Jafari. So this study, they interviewed 33 clients, clinicians, and staff at a community care setting that was providing IV antibiotics for deep tissue infections among people who inject drugs. And this study was based out of Vancouver, I believe. And in this study, they were examining this community care setting as an alternative to inpatient hospitalization. And early discharge was one of the key outcomes that they looked at. And so what they found was that the patients who received care in acute care settings, they reported leaving early due to negative social and psychological responses from clinicians and felt that they were stigmatized and were judged. And so similarly, or ultimately, you can see that there's a number of similarities between these studies that I've cited, in that there are some kind of common shared experiences between people who use drugs who are leaving acute care settings early, and some of their reasons for doing so. So interestingly, high rates of early discharge exist even in specialized addictions treatment settings. And I wanted to know why. So this brings me to my PhD research. And so I work with inpatient addiction services and observed frequent early discharges among patients. However, in these settings, the clinicians are very familiar with withdrawal management, very familiar with substance use. They know how to manage them. They've chosen to work in these settings. And so I wouldn't expect that patients would be leaving because they've experienced stigma or inadequate withdrawal management. And so this was something I was very curious about, because I'll get into the statistics in the next slides, but there's sometimes in some settings quite significant rates of disengagement from care. And so one objective of my PhD research was to understand precipitants of early discharge and experiences of the early discharge process from the patient perspective. So for my doctoral research, I focused on early discharges from inpatient withdrawal management settings specifically. And I focused on this particular setting because withdrawal management is a critical point in the trajectory of addictions treatment for many people. And it may represent the beginning of somebody's recovery journey. However, withdrawal management alone is not considered treatment for a substance use disorder. And rather, withdrawal management settings are places where people withdraw physically and psychologically from substances or stabilize on medications to help treat their substance use disorder. And the ideal scenario is that people should transition from withdrawal management to ongoing addictions treatment services in order to continue with their recovery goals, whatever those may be. And so when people leave withdrawal management settings early, they may be missing opportunities for further treatment engagement. So as we discussed earlier, between 1% and 2% of discharges from acute care settings in Canada are classified as early. But in inpatient withdrawal management settings, the rates are substantially higher, with rates ranging between 14% and 63% reported in the literature. And in the setting that I recruited from for my own research, the rate of early discharge is around 16%. So my research, oops, I gave away my findings here. My research began with a scoping review of the academic literature, which examined predictors of and reasons for early discharge from inpatient withdrawal management settings. And this scoping review included 62 studies, which were published over several decades, like I think it was 40 or 50 years. And they found that perhaps most strikingly, there's little known about why patients leave withdrawal management settings early, with no qualitative interview studies published on this topic. And there were some other key findings from the scoping review related to factors that predict early discharge, so like quantitative factors. But I'm not going to focus on that for the purpose of this presentation. Although if you are interested, there's a reference for the published scoping review at the end of the presentation. So the scoping review findings, in terms of my PhD research, they informed the design of two separate studies, and one was a retrospective cohort study. And the objective of that study was to generate evidence on possible predictors of early discharge using sex stratified models. And the other study, which I will explain in greater detail in this presentation. So the retrospective cohort study, I mention it here so that you know it was part of my PhD research, but for the sake of time, I'm not going to go into the details of it and the findings. So anyway, I will describe the qualitative descriptive study in greater detail. And the objective of that study was to document reasons for and experiences of early discharge as described by people who had received care in an inpatient medical withdrawal management unit. And ultimately, the overarching objective of these studies was to generate information that could inform possible interventions to prevent early discharges from inpatient withdrawal management settings, and also to identify areas for further research. So the research questions informing my qualitative descriptive study were as follows. Number one, what reasons do patients provide for leaving inpatient withdrawal management early? And number two, how do patients describe their experience of the process of an against medical advice discharge? And the second question I asked, because of the literature that we talked about at the beginning of this presentation, which suggested that AMA discharges and the language that we use around them is stigmatizing and antagonizing. And so I wanted to see what patients actually said about the process of an AMA discharge itself. So this study involved recruiting patients who had recently experienced an early discharge from the medical withdrawal service at the Center for Addiction and Mental Health. And to be eligible, participants had to be adults who could speak and understand English and had to have had an early discharge within the past 3 weeks. So that was just for the purpose of it being a recent event that they could easily recall. And the sample size was 13 participants. My total sample size, recruitment was challenging. And they were recruited by consecutive sampling. So that meant that every person who met the study inclusion criteria was approached and invited to participate. Potential participants also received study information flyers as part of the early discharge process, so they could opt to contact me directly if they wish to participate in the study. And I had 3 people who reached out to me actually requesting that they take part in the study. So the data was collected via semi-structured interviews that I conducted over the telephone that had the reason for that was because the medical withdrawal service at CAMH serves people all over the province. And so not everybody lives in Toronto, and it can be difficult to have people come back for the purpose of an interview. And of course, it was COVID while I was recruiting. And so things had to be done virtually or over the phone. So the recruitment, data collection, and data analysis, that process occurred simultaneously, and the data were analyzed using a conventional content analysis approach. And saturation was achieved when I was seeing replication in the data set, where I was seeing repetition in the categories and themes in the final interviews that I conducted. So now I'll describe the details of the study population to give you a sense of the people who actually participated. And the mean age of the participants was 36.2 years, with a range from 26 to 63 years, so quite a broad age range. 77% of the participants were male, and 92% identified as cisgender. 54% of the participants lived in Toronto, with the remainder living outside of the city. 54% of the participants were single, and 92% did not have children. 54% of the participants were employed, and 46% had been admitted and received treatment for alcohol withdrawal only, while the remainder were receiving treatment for alcohol plus another substance, or GHB withdrawal alone, or they were withdrawing from opioids only. So there was a mix. In terms of referral sources, 38% were referred through the CAMH emergency department. Another 38% were self-referred, and the remainder had been referred by a community healthcare provider. 62% of the participants had previously had an admission to the medical withdrawal service, and of those who had a previous admission, 75% of them had never had an early discharge before. So there were 3 themes reflecting the reasons the participants chose to leave early. And one theme was the impact of COVID-19, where infection control measures, exposures to the virus, and isolation requirements precipitated the early discharges. Unfortunately, I was recruiting for this study during the 2nd and 3rd waves of the pandemic. And so Toronto was under some pretty stringent public health measures. And so perhaps not surprisingly, factors related to the pandemic featured prominently in participant narratives of their hospital experience. But what stood out to me in what they talked about was how much patients were affected by the requirements to reduce contact and patient activities on the unit. And it became clear to me through these interviews that despite feeling really, really unwell during withdrawal, that patients really value the distractions and peer interactions as part of that process. And I suppose that's why that was somewhat surprising to me, is because when people are going through withdrawal, like they're feeling pretty rough. And I suppose I was surprised by the degree to which people, despite feeling that way, still really wanted to interact with one another. And that stood out to me as a factor that improves engagement in withdrawal management settings. And so another theme was dissatisfaction. And so some participants described being dissatisfied with some element of their care. For some, this related to being unable to access their desired aftercare program and transition directly into it after their withdrawal management. And they were feeling, and so some others were also feeling like they weren't receiving enough medication. And then others described the challenges in being unable to freely come and go from the unit to get fresh air and to smoke. And so you can see that there's a few different factors that comprise this theme of dissatisfaction, but that was sort of the overarching idea, that there was just these pieces that people were unhappy with that precipitated their discharge. And last, some participants left because of external pressures. And so these participants had obligations related to their employment or their loved ones, which they just had to prioritize over being in hospital for withdrawal management. So some of these participants talked about being in the position of like, either they lose their job or like they just have to leave. Like they were kind of in the position of having to choose work or their recovery, and weren't in the position to lose their job. And so these were some of the challenges that people were struggling with, and trying to navigate while they're getting help for a substance use disorder. So there were also 3 themes describing participants' experiences of the process of early discharges. And one was hitting a wall. And this was an interesting one because participants, and almost unanimously, described this common experience of reaching this peak frustration and emotional intensity. They talked about, like, I feel like I'm losing it. I feel like I'm going crazy. Like I'm feeling claustrophobic. And they had this, that it just led them to conclude that they had to leave. And though there were typically strong emotions happening, they also highlighted that their decision to leave was rational. It wasn't impulsive. And that was something that they made a point to talk about in their interviews. Another theme was difficult conversations, where participants described tensions in the conversations surrounding their decision to leave early. And so some participants actually took steps to solidify their decision to leave early before they even talked to staff about it, because they were anxious to do so. Like they didn't want to tell the staff. And so they would pack up their bags, and like have their backpack on. They would call their ride. And then, you know, the staff would obviously try to convince the patients to stay, but then the patients would remain firm in their decisions to leave. And so this created some tension and conflict and awkward feelings. Participants also talked about how the AMA form that they received was intended to provide legal protection to the hospital. And some actually disagreed with this designation, and some were confused by the fact that their discharge had been labeled against medical advice. And last, participants had mixed perceptions of their early discharge experience. And so some felt that their early discharge was handled well, while others did not, and they were feeling like they were being treated differently than they would be if their discharge had been planned. And so some described what sounded like a fairly normal discharge process, while others felt that there were a number of things that didn't happen that should have, such as receiving paperwork or medications or prescriptions. So now we'll move on to talk about clinical implications and future research. And so I'm focusing on this both from the results of my own research, but also from the larger body of literature regarding early discharges among people who use drugs. So first, I'd like to start by talking about some interventions to prevent early discharges. And so based on the literature I cited earlier, there's definitely a need for acute care settings to incorporate harm reduction into their practices. And so some examples could be providing clean needles or supplies and or facilitating access to supervised consumption services. And there's actually a really interesting example of this at a hospital in Edmonton, where there's a supervised consumption service actually embedded within an acute care hospital, and which allows inpatients to use substances in a safe environment and to also continue accessing their medical care where they may otherwise sort of depart the hospital or leave against medical advice. I think it's also important that clinicians receive training and support to manage withdrawal effectively. And as you noted or would have noted, the participants in the studies I cited frequently spoke about receiving insufficient pain management. And so it's really important that clinicians be aware that someone with a really high opioid tolerance will often need quite high doses of opioids to achieve control over acute pain. And last, ensuring that patients have low barrier access to opioid agonist therapy and don't experience disruptions to their opioid agonist therapy if they're already on it is essential. And I mean, I would also like to highlight that it's imperative for nurses and other healthcare providers to receive training on substance use and harm reduction in their formal education. And I think this would go a long way in increasing clinician knowledge and confidence and ultimately improve the care of people who use drugs. However, it's like from my understanding in some literature I've looked at least within nursing education, is that addictions curriculum is sometimes sparse and inconsistent across the country. And so my hope is sort of moving forward, we can increase the content that we deliver in our formal nursing education to help people feel more prepared to care for people who use drugs in all kinds of different clinical settings, and ultimately help to improve the care they receive and their experiences of care. So now focusing on withdrawal management settings, based on the findings of my research, it's definitely clear that there's a need to carefully balance infection control requirements with opportunities for patients to engage with one another. And my hope is that this becomes easier to accomplish as we move forward with the pandemic. It's seeming optimistic now, but I expect that there'll be infection control measures in place for some time still. And, something that I wonder about is opportunities to increase peer support presence and support, and have peer support workers who are trained in infection control who can kind of help engage and provide support in that peer-to-peer kind of way. I think something that stands out to me is the need for continued advocacy for accessible and evidence-based residential addictions treatment services. And some participants in my study, they left because they couldn't transition into the residential treatment after their brief period of withdrawal management. And they felt that relapse was inevitable for them if they weren't able to have more time removed from their normal day-to-day life. And as I mentioned, there were also participants who were dissatisfied with their withdrawal management protocols. And though this was a less common reason for early discharges relative to some of the other themes that I found, I think it's a really important reminder, not just in withdrawal management settings, but in the healthcare system at large, to continuously evaluate the effectiveness of our withdrawal management protocols and revise them as necessary, especially in the context of evolving potency of street source substances, which has certainly challenged us and required us to evolve in terms of how we're managing withdrawal. And so something else that stands out to me is the need to improve the early discharge process itself. And so as I described, some participants in my study, they had competing priorities that just made it very difficult for them to remain in hospital. Like they were having to make some really difficult choices. And so when people, when they need to leave the hospital, I do question the value of engaging them in this unpleasant process of telling them that they're leaving against medical advice and asking them to sign this serious sounding legal form. And in fact, some have argued that a signed AMA form actually doesn't confer any legal protection. And really it's the execution of a good discharge process that protects providers. So ultimately, the focus should be on the client's capacity, their understanding of their condition, their treatment options going forward, and what could potentially happen if they decide not to accept the proposed treatment. And then, of course, documenting that discussion. And that documentation is really what would stand up to any sort of legal scrutiny. It has also been suggested that this AMA language and form signing process is really, it's focused on provider fear of legal liability. And what it does is that it shifts the conversation away from the patient and their discharge planning and more so to making sure they know they're leaving against medical advice and having them sign this form. And so here, I've included a screenshot of an article about AMA discharges that was published in the Journal of Hospital Medicine as part of a Things We Do for No Reason series. And it's an interesting read. And this David Alfondre has actually published extensively. He's even written a book on this topic. So this is an interesting read, and it provides some food for thought in terms of challenging this arguably antiquated practice that we have in our healthcare settings. And so there are definitely ways that the early discharge process can be improved. And first, as I've already described, is to change the language that we use. As I talked about, I provided examples, I've been using the term early discharge, but I'm not committed to that. I think informed discharge or patient-initiated discharge are also suitable alternatives. I would also recommend that hospitals explore eliminating these AMA forms altogether, or if they can't, at the very least, modify them so that the language is more neutral and patient-centered. Now, as I described earlier, the conversations when people are leaving early should focus on a client's capacity, their understanding of their condition, alternative treatment options. Receiving care in an inpatient setting isn't always the only option available. And one finding from my study pointed to a need to improve consistency in the management of early discharges. And so this could involve doing things like creating checklists, or training to support consistent and helpful responses when a patient expresses the wish to leave early. And another example could be creating early discharge packages of resources for patients so they could contain crisis resources, information about withdrawal or whatever their health condition may be, information around how to access services in the future, harm reduction supplies, transit tokens, like any variety of things. In acknowledgement that someone just may not be able to stay in the hospital, and these are just things that could be done to help improve the process and the patient experience of leaving early. And last, we can also frame our discussions in terms of how the client might reduce harms associated with not completing treatment at that time, and how they may stay safe at home or in the community. So in terms of future research, there's definitely a need to test and evaluate interventions to prevent early discharge. And thus far, research has focused on characterizing the problem and makes suggestions to improve it, including my own research, but I haven't come across any intervention studies. And such studies could be really interesting opportunities to engage patients and even co-design interventions to prevent early discharges, and could potentially be like a really interesting opportunity for QI initiatives in different settings, because I do acknowledge that depending on the setting and context, people may have different reasons for leaving early, and different common factors that precipitate it. And so, we could develop unique individual interventions within different types of services. Something else going forward, I think it's really important to examine nurses' perceptions of their roles and responsibilities with respect to early discharges. And so interestingly, through all of the papers that I've read on this topic over the past many years, there's been very little commentary from the nursing perspective. And the issue of early discharge, it's been primarily discussed by physicians and is seen as a physician issue. Yet, I've also seen several papers that highlight that nurses are often the authors of clinical notes pertaining to early discharges. And so for this reason, I do think it would be worthwhile to explore the unique perspectives and challenges that nurses may face in navigating early discharges. And so there's a list of references and all the papers that I've cited throughout, and this will be available via the email that goes out after. And thank you. Thank you so much for being here today and listening on this beautiful day. And I look forward to your questions. And I'm going to stop sharing my screen now and invite questions.
Thank you so much, Sarah. Please feel free to raise your hand or to put any questions in the chat box. Definitely a lot of food for thought. Maybe everyone's still mulling it over. Does anyone have a question? Please don't be shy. Susan, please go ahead.
Hi, thank you for your very informative presentation. I'm a nurse educator in general internal medicine at an urban teaching hospital. And I'm interested in particular in your recommendations around the early discharge kit. If you could talk about that in a little bit more detail, because I'm wondering if a naloxone kit should be part of that as well.
Yeah, that's a really great point. And it's something that we do for our early discharges, like if it's relevant to their substance use history, of course, like a naloxone kit is something that we're offering to people before they're going out the door. And I think it can vary depending on what is an option within within your particular setting. And I know within different hospitals, like there's different requirements for patient training around the use of the naloxone kit before we give it to them. I know that in this setting that I've talked about in my research, our pharmacists, as soon as someone comes onto the unit who uses opioids, they engage in the naloxone training as soon as possible, so that they do have an early discharge. The nurse can just hand that naloxone kit over as part of that process. But like I said, I do think it would be a good way to help standardize the process, because I'm well aware that people leave early at all times of the day and night, and different days of the week. So one aspect of my research that I didn't talk about was looking at predictors of early discharge. And we found overwhelmingly that like a very high risk period of time for people to leave early is on the weekend. And that, of course, is when our regular attending physicians aren't there. Like there's fewer staff members there. So it can be very challenging for teams to deal with in a consistent way. And so by creating the packages with crisis resources, or even like just checklists for the teams to follow, and kind of creating a standardized process for this, I do think it could go a long way in improving patient experience when they just have to leave early.
Thank you.
Does anyone else have any questions? Okay, well, I think we'll leave it there for today. Thank you so much again, Sarah, for your great presentation. We really appreciate your time and you sharing your work with our alumni community. I would like to thank all of you for attending as well. And I want to let you know our next Lunch and Learn session will be on April 28th with Dr. Erin Conway, discussing machine learning to improve clinical alarm management. So we hope to see you there. In closing, I just want to thank Laerdal Medical Canada again for supporting this Lunch and Learn series, and to thank my colleagues Shauna Spicer and Carolyn Peralta for organizing today's event. Thank you so much, everyone, and enjoy the rest of this sunny day. Take care.
Thanks, everybody. Thanks for joining.